Good morning, dear audience. Today I'm going to present my ongoing research on the advancements in the diagnostics of skin cancer. Let me briefly introduce my first topic. Basal cell carcinoma is the most common cancer in humans, causing severe disfigurement if not diagnosed early. Current gold standard diagnostic technique, histology, is invasive. We lack fast, non-invasive, and highly accurate diagnostic tool in the everyday practice. Our research evaluated novel optical imaging techniques and found two clear winners. Line-field optical coherence tomography and reflectance confocal microscopy showed a sensitivity, specificity, positive and negative predictive value of more than 90%. This is why we encourage dermatologists to implement these tools into the everyday practice to reduce unnecessary biopsies. And future studies should focus on cost-effectiveness of these tools. I am Kelemen, a medical doctor and a PhD student at the Department of Dermatology, and my vision is an early diagnosis and treatment of skin cancer. And to achieve this, my mission is to improve skin cancer detection through imaging methods. I have two ongoing projects, both focusing on skin cancer detection, first one on basal cell carcinoma and the second one on melanoma. So let's start with the first project, which is investigating the accuracy of novel optical diagnostic imaging techniques for basal cell carcinoma. BCC is the most common cancer among humans, with a 10% incidence rate in the Caucasian population. While it is generally slow-growing and less likely to metastasize, untreated BCC can lead to severe local complications such as significant disfigurement and loss of function. Current gold standard diagnostic method is histology, which is invasive and time-consuming. While dermoscopy is non-invasive, its accuracy depends on the examiner's expertise. This is where novel optical diagnostic tools come in the picture, as they offer a real-time, non-invasive diagnosis. We have a wide range of tools with unclear accuracy. For example, optical coherence tomography has high penetration depth, while reflectance confocal microscopy has high resolution. So our aim is to assess the accuracy of novel optical imaging techniques in the detection of BCC. Our clinical question is which is the most accurate tool among these, and to answer this we have the PIRD question framework, and we will compare novel optical imaging tools to the gold standard histology among patients with suspected BCC. We hypothesize that RCM will prove to be the most accurate one, and with this we could have a quick patient-friendly diagnosis of BCC. Here you can see the search key I have used to conduct the systematic searches in 3 databases, and this resulted in almost 4,000 articles. And after the selection process, in total we ended up with 30 articles. Let me show my results. Here we focused on 2 main outcome parameters, sensitivity and specificity. These reflect on how well each tool can detect BCC when it's there and rules it out when it's not. These are unitless metrics ranging from 0 to 1. And we had enough data on LC-OCT, RCM, and OCT. These diagrams are summary ROC curves. Each dot represents one single study, and the blue square in the center is the summary point estimate. On the x-axis, we have 1 minus specificity, and on the y-axis, we have sensitivity. And we can see that most of our studies cluster in the top left corner, indicating a strong and consistent performance. However, we have some outliers, and the reason for that is the prevalence of BCC was varying across our studies. Overall, here you can see the sensitivity and specificity of the imaging tools, and I'd also like to introduce 2 other more very important outcomes, positive and predictive values, which reflect on how well each tool actually perform in the everyday practice, and these show us how reliable the test result is. So we can see that RCM and LC-OCT had very high numbers, and OCT had somewhat lower specificity and positive predictive value. These results are clinically and statistically significant, indicating that these tools should be implemented in the everyday practice. I'm happy to announce that this is the first meta-analysis of several optical imaging techniques for the detection of BCC, and we had a relatively high patient number. Of course, we had our limitations, the limited number of studies available for LC-OCT, and what I have mentioned, that the reported prevalence of BCC was varying across the studies. In conclusion, we can say that LC-OCT and RCM showed sensitivity, specificity, positive and negative predictive value of more than 90%, while OCT seemed to be less reliable for accurate BCC detection. Our implication for practice is that dermatologists should incorporate these tools into the everyday practice to reduce unnecessary biopsies, and for these we would need training programs. Our implication for research is that the cost effectiveness of these tools should be investigated, and there are also other novel imaging techniques that could be investigated. Now we didn't have enough data for that. Here you can see the progress of this first project. Now we are focusing on writing the manuscript. And let's move on to the second project, which is investigating the diagnostic accuracy of dermoscopic scoring systems in the detection of melanoma. Melanoma represents approximately 5% of all cancer cases and has the highest mortality among skin cancers. The most widely used non-invasive diagnostic method is dermoscopy, which I have mentioned. Its accuracy is very dependent on the examiner's expertise, and also there are several scoring systems or algorithms that are used during the diagnostic process. So we have different algorithms worldwide. For example, the ABCD rule is probably the most well-known, but we have the pattern analysis and, for example, the 7 checklist method. And there's no consensus on the most accurate one, so this is why we think that we could standardize the diagnostic process with having one highly accurate algorithm that could be used by everyone. So our aim is to assess the accuracy of different dermoscopic systems for the detection of melanoma. Our clinical question is which is the most accurate one among these different algorithms, and to answer this we will compare different dermoscopic scoring systems to, again, the gold standard histology in suspected melanoma patients. We hypothesize that pattern analysis will prove to be the most accurate one, and with this we hope to improve the diagnostic accuracy in the detection of melanoma. In summary, I have 2 projects ongoing. The first one I hope to finish this summer, and the second one in 2026. I'd like to close my presentation with a quote from the English poet William Blake: "What is now proved was once only imagined." Thank you for your kind attention.
You talked about cost effectiveness, so that probably the diagnosis of BCC would be much higher if we would use these techniques. Can you maybe guess how much higher the cost would be for each patient?
Well, I don't have an exact number, but what I have saw in my preliminary searches, that cost effectiveness of RCM was already investigated, and they found that in the long run it would be maybe more efficient to use this, for example, the RCM, to use it in the long run than do biopsy on everyone. Because there are countries where they biopsy all lesions that are suspicious for BCC.
Can you a bit explain for us how these imaging techniques works?
Yes, thank you for your question. So these what I have mentioned, LC-OCT, RCM, and OCT. RCM uses laser and gives us a superficial image, while, for example, OCT has a high penetration depth. It uses near-infrared or infrared light, and it provides us a cross-sectional image. As I mentioned, OCT is very good in penetration and RCM in resolution. And LC-OCT is almost a combination of these benefits because it's a novel technique of OCT, and it has a higher resolution than RCM and higher penetration depth than OCT. So it combines the benefits of the two other techniques.
Can I ask you, how would you like to implement these imaging techniques in the diagnostic process?
Yes. Our goal was to replace histology, but I think dermoscopy and histology will always be part of the diagnostic process. What we want to do is, in cases where the dermoscopy is not definite, then the second step would be one of these imaging techniques, but obviously there would be cases where this wouldn't also provide a definitive diagnosis, so then we would do the biopsy.
What do you think? What is the reason behind the lower specificity of OCT compared to the other methods?
Well, I think probably is the lower resolution that could be behind it.
Kind of follow up from that question, would you recommend OCT as a treatment then, because of the lower sensitivity compared to the other ones?
Yes, I said that it had less reliable results than the other two, but OCT can be used for other things in the diagnostic process, also for BCC, for example, subtype, and to determine the subtypes, and also OCT is, can be used in other skin lesions, not just BCC, but other skin cancers and other type of lesions in dermatology.